So I went 5 minutes over my time, so I apologize. I'm not going to give a very detailed introduction, but Dr. Adams is a breast cancer expert, an expert on immunotherapy, and Dr. Friedman, a GYN oncologist from Memorial, and expertise in GYN tumors, and Dr. Manji is a GI gastrointestinal cancer expert from Memorial Sloan Kettering. And So I guess I'll start off. So Dr. Adams, there's been like a lot of development and excitement in the breast cancer world. I know breast cancer is actually a major public health impact, and we haven't actually seen immunotherapy work that well in breast cancer, despite of several previous attempts. And recently, there have been like a lot of really exciting developments. Could you please walk us through some of those trials?
Sure, my pleasure. So just to introduce myself to you, I'm a professor of medicine here at the NYU School of Medicine, and I direct the newly established breast cancer center here at our Perlmutter Cancer Center. And I'm very excited to actually see lots of patients, families, and friends in the audience, and I'm very grateful that you came out to this important event. And also happy to say that I've shared my last at least 2 decades of my life and my work and passion with immunotherapy. And I've been very grateful to the CRI for actually doing lots of the basic science research and initiation of clinical trials to change the standard of care. That is so critical. And when we started in the late 90s with cancer vaccines, we were able to actually induce responses against certain antigens, but only over the last decade or so, the mechanisms by which cancer actually downplayed these sniper cells, as you heard before, were discovered. And then powerful molecules led to the development of these immune therapeutic antibodies that now actually are able to cure advanced cancers, which is very, very exciting. And I've been, really, really happy to take the lead in breast cancer in this field. So what do you need to know about breast cancer? We've actually, over the many years that breast cancer has been successfully treated with endocrine or hormone therapies, chemotherapy, and others, there are some major advances, including increases in cures with standard treatments, including, for instance, antibodies against HER2. So subsets of breast cancer already benefited from certain immunotherapies. You may know the drug trastuzumab, which is an antibody against HER2. And there is some action through the immune system, not just direct cell kill. And so we had in breast cancer some successes before, but there are other subtypes of breast cancer, such as triple-negative disease that has no targets, really, that we treat with hormonal agents, HER2 agents, and just chemotherapy was basically available for those tumors. So the big advances in breast cancer have been in the field of triple-negative disease, which is a very, very, very poor prognosis tumor, as you may know. So it doesn't have the estrogen receptor, it doesn't have HER2. And women who have advanced triple-negative breast cancer have a life expectancy usually of 1 year. These are very young women in their 20s, 30s, 40s, 50s. And 1 year or 1.5 years is not enough. So for those patients, we were able to actually figure out that some of those tumors already have these sniper cells in the tumor when they get diagnosed. And because of that and clinical trials that we helped with, there was an approval last year, or actually this year, the first immune therapy with checkpoint inhibitors, as you've seen in the talk, in combination with standard chemotherapy. And that's been the major advance for breast cancer so far. And I'm happy in the afternoon session to talk a bit more about this study. This was a very large multi-center international trial that led to the FDA approval. And it was for women who basically were just newly diagnosed with metastatic triple-negative breast cancer. And comparing the new combination with immunotherapy to the chemotherapy standard that we had, which I told you is resulting in survival duration of about 1 year or 1.5 years. For the first time, we actually came across the 2-year mark. So we were able to really make a difference for patients. It's still not enough, but it is the first time we have seen that. And this is very exciting. And we're working currently to add different other compounds to it to actually make it more effective, longer term treatments, and also to help patients who don't have those inflamed tumors, as you heard. So that was a long introduction, but I hope that this answered the question. So last year and this year, the first approvals for immunotherapy in triple-negative breast cancer, and we hope to expand that into other subtypes, into earlier cancer, and I'm happy to answer those questions also in the afternoon.
And Dr. Adams, so do you have any studies going on in early stage breast cancer that you're excited? Sorry. So, Dr. Adams, are you familiar or excited about any early stage lung cancer patient, breast cancer patient trials? Can't get lung cancer out of my head.
Absolutely, because I think what we've seen in all of our studies is that the earlier you treat the patient, the better the outcome is. So once you have metastatic disease, usually if you get the immunotherapy in the first setting, you have much better chances of having durable cures, long-term responses, than if you use them after many rounds of chemotherapy. So actually now moving it into an early stage breast cancer, there was just an exciting announcement a month ago, so that there was the first trial showing very promising results, meaning that you were able to actually eradicate the tumor in early triple-negative breast cancer when given in combination with chemotherapy before surgery. So at time of surgery, there was no cancer left. And that extra percentage of patients who achieve that, what we call pathologic complete response, translates very likely into increased cures. So yes, it will definitely also go into earlier settings.
And in terms of biomarkers for selecting patients who could benefit most from these drugs, in breast cancer, I know the trials that were done so far were using certain assays for selecting. So what is your take on biomarkers for breast cancer patients to select for immunotherapy treatments? So
right now we are using the PD-L1 stain, which is what you had in the discussion before. This is just a marker in the tumor that shows that the shield is up for the cancer to protect itself from the T cells, from the killer and sniper cells. And for the benefit to happen in breast cancer, you have to express at least 1% of those cells in the tumor, not in the tumor cell, but in other immune cells that are in the tumor, to make it work. So that happens in about 40% of patients with triple-negative breast cancer. And right now, that's the only marker we have. It's not ideal, but there's tons more research that we need to do.
Thank you, Dr. Adams. Any questions for Dr. Adams? So we're going to move on. And
yes, you spoke to
okay, can you hold for a second? We'll get the mic. Can you repeat the question?
You spoke to the triple-negative trials, and the trials that I do read about and see listed are often triple-negative trials. What work is being done with PD-L1 or some of the other markers for the more common types of breast cancer, such as PR and ER positive, HER negative, or I guess that would be HER negative?
Again, I would like to go into much more detail this afternoon because we have other cancer specialists here. Very briefly, the hormone-positive breast cancers, which are actually the majority of breast cancers, as you mentioned, have less of an immune suppression, and those current treatments, the current immunotherapies, are somewhat less applicable to them and not as effective. But there are pathways that are potentially responsible for that. So we are finding targeted treatments for hormone-positive breast cancers and also HER2-positive breast cancers that turn on more of the immune reactivity in those tumors, and then combining those newer treatments with immunotherapy. So we're definitely looking at the advances across all breast cancers. It's not only triple-negative breast cancer, but there are different pathways we need to attack in these other subsets.
Can we get the mic? We have a question here.
We're actually going to wait, and we're going to do questions at the end for the last 15 minutes.
Okay, that's good. All right. So, Dr. Friedman, in your area of research in GYN malignancies, I know there's been a lot of excitement recently about certain specific subsets, like the MSI high tumors. Can you tell us a little bit about your research and what you see is the most exciting thing in GYN tumors at this time?
Sure. Okay, I moved up my mic. Can everyone hear me? Yes, okay. So, hi, I'm Claire Friedman. I am unique in that I'm a GYN medical oncologist. So, as you all may or may not know, most patients with gynecologic cancers in the US are taken care of by gynecologic oncologists who do OBGYN training and then go on to do additional surgical training. Memorial is one of the few institutions where the surgeons operate, and we have medical oncologists who take care of women who, for systemic treatment options. So I am a medical oncologist. And I both see patients with gynecologic cancers as well as run early phase clinical trials. So you are absolutely right. There's been a lot of excitement in gynecologic cancers. We are lucky enough now that we have FDA-approved immunotherapy options for both women with cervical cancer as well as a proportion of patients with endometrial cancer. So about 30% of endometrial cancers carry a property called mismatch repair deficiency, where essentially there's a lack of some of the genes that normally repair DNA. And how I describe this to my patients is that, every time a cell divides, it's making a Xerox copy of a Xerox copy. The DNA gets a little smudgy over time. And when you are lacking those genes that normally repair the DNA, that those smudges become even more pronounced. And what that translates to is those cells start to look more and more abnormal, and perhaps it's easier and easier for the immune system to recognize those cells and kill them. So pembrolizumab, also known as Keytruda, is FDA approved for patients with mismatch repair deficient endometrial cancer who have advanced or metastatic disease. So that's fantastic. We've seen amazing responses in those patients whose tumor carries that quality. But again, it's about 30%. So I think we're really hoping to expand the number of patients with gynecologic cancers for whom immunotherapy is a good option. I think one of the most promising approaches is being led by one of my colleagues, Dr. Vicky Macker, which is looking at a combination of two medicines, pembrolizumab or Keytruda, plus a medicine called lenvatinib, which is an oral medicine that seems to modulate a number of different kind of factors within the tumor microenvironment. So again, for a lack of a better way of describing it, it makes the tumor microenvironment leaky and lets immune cells in. So that combination showed great promise in early phase 1 and phase 2 clinical trials, with about 50% of patients seeing a shrinkage in their tumor, irrespective of whether their tumors carried that mismatch repair deficiency. And that combination is now in a large international randomized phase 3 trial. So I think that's probably the most exciting thing that's up and coming within gynecologic cancers. And the combination actually has gotten fast-tracked by the FDA for approval. I think the area that we are hoping to see the most change in is ovarian cancer. So response rates to the single-agent PD-1 drugs like pembrolizumab or nivolumab have been fairly modest thus far, along the range of kind of 10 to 13%. And it's interesting because ovarian cancers, they tend to be fairly inflamed, as we say, right? When we look at them, a significant portion of them will show a high degree of immune infiltration. So you would think that these would be the types of cancers that would respond beautifully to PD-1, but they haven't yet. So that's certainly an area of rich research for me. So thinking about how we can combine immunotherapy approaches with perhaps chemotherapy or other medicines like chemotherapy or PARP inhibitors or things like that to help bump up that response rate.
And Dr. Friedman, there have been like a lot of trials looking at cell therapy-based approaches especially for ovarian cancer. Mm-hmm. Can you speak a little about that? And if you feel that's an exciting... So the question was, there are a lot of exciting trials with cell therapy-based approaches in ovarian cancer, and we were hoping you could talk about some of those trials and see if that's something that's exciting or something to watch out.
Yeah, so again, it's an area of rich exploration, both at Memorial Sloan Kettering as well as some other academic institutions. University of Pennsylvania comes to mind as being a center of excellence for modified T-cell therapy. The primary target thus far has been something called MUC16, which is a protein that's commonly expressed on the surface of ovarian cancer cells. We do have a clinical trial that's early phase 1, really looking for safety data, looking at a modified T-cell program. I think it's exciting. It's an exciting approach. Early days still yet. There is, a fair amount of toxicity associated with these approaches. They require hospitalization. It's not kind of a light undertaking, but it's certainly exciting, and we're hoping to see some good results soon.
Right, and Dr. Manji, in your area, like GI tumors, gastrointestinal tumors, even in GI tumors now, we've had like some interesting developments in terms of MSI high tumors and approvals there, and beyond the MSI high tumors, we haven't really seen much progress in terms of immunotherapy, and especially for pancreatic cancer, we haven't really seen any responses there, like very low response rates. So what's your area of research, and could you shed light on why certain GI tumors are so recalcitrant to immunotherapy?
Sure. Just as introduction, I'm a physician scientist at Columbia University, where I study mouse models of pancreas cancer, really focusing on the tumor microenvironment. And just to put it in layman's terms, what is a tumor microenvironment? Basically, tumor microenvironment is a neighborhood. And every cancer has has a different neighbor, a neighborhood. So if you're going to go ahead and sort of try to go and extract somebody in a different neighbor, you need to know which neighborhood you're going to. So you have to really understand where these cancer cells are living. These cancer cells are not living independently. They're living, with a structural environment, with their neighbors. And unfortunately, what happens is that as the cancer grows, the neighbors actually cooperate with the cancer cells and do not allow the COPs or the immune cells to enter in. So you really have to understand what the landscape is before you start just combining, immunotherapy or chemotherapy or different targeted therapies to understand which mechanisms are being used not to allow these COPs to come in. For example, if you're going to go to New Jersey from here, either you need to cross a bridge or you need to have a way to cross the Hudson River. Or compared to if you're going to go to Bronx, that you're not going to have that issue. So you really need to understand, what does a breast cancer look like? What does a pancreas cancer look like? What does a colon cancer look like? And unfortunately, it's more complex than that. Once you get into the breast cancer or pancreas cancer, it's not one disease. It's a subtype of diseases, and you need to add the complexity even further. So, just to go to New Jersey, Newark is going to look a lot bit different than, Englewood versus. So you have to really understand, and that's what we try to do in the lab. We use mouse models of pancreas cancer where we have genetically engineered mutations that we know are very important, critical. In pancreas cancer in humans, and then what we have done is we have selectively allowed these mutations to express in the pancreas tumor, and then what happens is that we actually see that the pancreas tumor forms. This was work done by multiple other previous scientists, and now what my focus is to understand as you mentioned, why does immunotherapy not work? What is the landscape like? What are the complex COPs? It's not just COPs. It's the FBI, the CIA. It's a very complex environment, and unfortunately, there are good COPs and there are bad COPs. So you have to really understand what type of COPs there are, which are the ones that you need to target, because now we have medications that selectively target, the good COPs to try and make them better. To try and suppress the bad COPs, which are the Treg cells. So we also have macrophages. So now we have drugs that specifically target macrophages. So in pancreas, coming back to your question, the reason that it's very difficult to target is that when I treat pancreas patients, and I tell them that pancreas, unfortunately, is like going in and trying to say, if you want to clear a block where you want to get rid of all these houses or huts, you have to understand. And unfortunately, pancreas is like a fort. So and what you have to really do is you have to understand the fort. You have to first get rid of, you have to unhook these electrical gates so that you're allowing the T cells to open. And slowly, we are understanding what the pancreas tumor looks like. For immunotherapy by itself has not worked in pancreas cancer. It has worked only in about less than 2% of pancreas patients. And the reason is that the mutation that you had initially mentioned, which allows multiple mistakes within the tumor such that the immune system can recognize it, it happens, in a very small proportion of pancreas patients. So for those patients, it'll work. But for the other ones, unfortunately, it's chemotherapy. But now we're learning more about the neighborhood, and we know that there was a recent clinical trial that was reported using CD40, which is an agent that targets macrophages and different Tregs. And what it's showing that in combination with chemotherapy, even though the days are early, the responses look fairly promising. The other combination is with hyaluronidase, which is a randomized phase 3 study that was done in combination with chemotherapy, in which what happens is that we realize that after studying the pancreas tumor, that it has a lot of structural components. I imagine that it's like a cell. It has many concrete layers, and in order to get to the tumor. So this company and these investigators designed a very smart experiment in which they first tested to make sure that there was a lot of concrete in their tumors. And then what they did was they had a specific drug that made holes into these concrete walls. And then they combined chemotherapy. And what they learned in these mice first, that these tumors actually responded better. And then these mice lived longer. And based on that, clinical trials were designed. So the short of it is that it is a more difficult tumor microenvironment that we have to understand. And the key thing, the only way that we're going to learn is by doing clinical trials, right? Doing the same thing over and over again and expecting, great results just does not make sense. And the only way that we're going to learn is not just by doing clinical trials, is actually going to learn, what the neighborhood looks like before you get treated and while you're getting treated. So if I'm designing a drug and I'm trying to make these holes in the concrete walls and the trial doesn't work, well, I have no idea if I don't have a biopsy tissue while the patients are in treatment and to look whether the holes were even made. It might be that I was using the wrong drill bit, So that is how we are going to learn, and that is, so that's why it's so critical for investigators, providers, and patients to partner and understand. I recommend when you're getting onto a clinical trial, you need to ask these questions. What is the rationale for this trial? What are we testing, and how are we going to learn? From failure, we need to learn. So we need to, say that this pathway is not relevant in this histology. That is, to me, just as important as learning when things work. And when things work, we need to understand, yes, it's working because we think we know what we're doing.
I think that's a very important point that you bring up, especially for clinical trials. We are so focused on, understandably, to see that drug work and actually demonstrate efficacy. But it's also very important to understand why a drug doesn't work, or if it works, what is it in that particular patient that is important for this drug to work. So being able to understand that is actually very critical. And some of these early trials, as some of you who have participated in clinical trials understand, they do require biopsies of tumor on treatment. And that's actually one of the major reasons why we do biopsies in clinical trials, to understand the science better, so we can actually help improve on some of these treatments and develop new treatments for patients in the future. So it's really important to consider that when you're actually enrolling in a clinical trial, understand why you're being asked to have those extra blood draws or extra biopsies. It's very important for physician scientists to kind of understand why a drug works or why it doesn't work. And we have 20 minutes for questions, so I'm going to open it up for questions.
We're going back to the first part.
Give me 1 second. Can we get the mic?
Someone asked, how do biomarkers help decide which drug is most effective from the live stream?
That's $1 million question.
So, Dr. Adams, I think you commented on that.
Which biomarker is important? I think that's the main question. For breast cancer, the approval for immunotherapy is for patients who have that PD-L1 positive tumor, but we need more trials that look at different biomarkers. So, for instance, one of the ones that we are interested in is to have the lymphocyte in the tumor, actually, and so looking at that as an inclusion criterion for trials. But again, it highlights the need for trials, and that is so important that many of you are participating and helping to understand what works and what doesn't.
And just to add to that, one of the challenges that we have with immunotherapy is even though there are certain biomarkers that can actually help inform and enrich for response, unlike targeted therapy, like for example, a patient with a HER2 amplified breast cancer or EGFR mutant lung cancer, we're not talking about a genomically edited tumor. So even though the patient's tumor might have high PD-L1, there may be other things also contributing to that interaction between the tumor and the host immune system. So it's a little bit more complex, and that's why we don't see high responses in even in tumors that have a high PD-L1, because it's a multidimensional interaction. And we're still beginning to understand how to kind of enrich for responses to immunotherapy. And as we understand the science better and understand these complex interactions between the immune cells and the tumor, I'm sure we'll develop better biomarkers.
I've just begun immunotherapy, and I'm wondering about the side effects that I'm having. I'm not sure which ones are due to the Opdivo that I'm getting in my veins and which ones are just age-related. And can you help me determine this? I don't know if you can, but it's a question I have. And also, at what point does one know whether the immunotherapy is working? Because I'm scheduled to have treatment over a year's time every 4 weeks, and it's already starting to have ill effects where I'm living on pain pills. So I'm just wondering, at what point does one know whether the treatment is actually working?
So I can take that question. As we discussed before, one of the key things to remember when it comes to immunotherapy is some of those very pathways that we're trying to target in terms of the immune evasive pathways in the tumor. Those are the same very pathways that actually help prevent autoimmune reactions. That is like your body's immune system to react to your own normal organs. And hence, like, some of those autoimmune adverse events are seen in patients who have immunotherapy. It's hard to kind of opine on your specific situation without knowing the details, but sometimes it gets complex because, like, for example, in lung cancer patients, if you have somebody who has like bad lungs and they have an infection or other problems like a pneumonia, and sometimes it gets really hard to kind of differentiate, is it because the immune system is reacting to normal lungs, or is it because of an infection? Sometimes it gets very complex. you definitely have to have a physician who has expertise in immunotherapy, who's actually considering all the other possible alternatives in terms of those side effects, and kind of work up and make sure we know exactly what's going on. Because unlike with chemotherapy or targeted therapy, where if you start developing some side effects and you stop the drug, most oftentimes those side effects resolve. Like if you have low blood counts from chemotherapy, you stop, the side effects tend to resolve. But with immunotherapy, if you don't recognize the problem and you keep getting the treatments, there is a possibility that it could actually become much worse. And also, when you stop the treatments, the side effects don't go away spontaneously. You have to actively intervene in terms of immunosuppressive treatments. So it gets a little bit more complex in managing some of these side effects with immunotherapy, and it's especially true with combination immunotherapy approaches. So to answer your next question on how do I know if it's working, typically like when somebody has a solid tumor, metastatic cancer, we do continue to monitor those patients' tumors with CAT scans or PET scans to see if the treatment's actually working. The thing with immunotherapy is that unlike targeted therapy or chemotherapy, where sometimes you see a very linear response. You give chemotherapy, the cancer is responding, and it's you see that on scans. On some occasions with immunotherapy, it doesn't happen that often, but it does happen at a rate that's much higher than chemotherapy and immunotherapy, targeted therapy, is that you could sometimes see a flare reaction where the cancers start having all this inflammatory response, and they actually appear bigger on CAT scans. But it's actually a very transient phenomenon, and oftentimes. It's a setting where the patient feels great, but when the patient's coming in and having those scans, the scans look terrible, but the patient's clinically feeling really well. So those are things some clinical nuances that you have to keep in mind when you're on immunotherapy. And sometimes you also see situations where there's a lot of fibrotic changes or like a lot of changes in the tumor that kill the tumor, but actually cause like changes that are persistent on a CT scan. It's called atypical response, or the cancer does not shrink, but it's stable, and it appears when you're looking at CAT scans, essentially you're looking at shadows. You don't really know how much of it is actually real cancer. So those are some clinical nuances that you have to kind of discuss with your oncologist who has expertise in immunotherapy. And most importantly, I think you have to keep in context the clinical situation. You have to make sure the patient's doing well, then look at the scans and actually make decisions on treatment based on that.
Can I also ask, maybe you can have Jill briefly chime in on the patient resources, because the CRI has wonderful information about immunotherapies, how they act, but also what side effects can happen with these special therapies and how they can be managed.
Well, thanks for the plug, Sylvia. Yes, I think if you go to our
Very
website,
important.
We do have, you don't have a computer, so you could call us and we could actually download information by cancer type in terms of what happens and what are the side effects. So there are a lot of resources listed that we can. Yes, you need that.
15 side effects, and I'm already at half of them with only one treatment, so I'm just a little concerned that I'm going to be worse off than if I didn't do this immunotherapy.
Well, I'm not a physician, but I guess, sometimes side effects means things are happening, so give us some time and follow.
Yeah, I just also want to make a quick plug that if you're on an immunotherapy clinical trial, so at least at Memorial, every single clinical trial has a clinical trials nurse associated with it. And I'm sure it's the same at all of our institutions. So please, if you're on a clinical trial and you're having symptoms, please let us know. The worst case scenario is you don't let us know and people can get quite sick quite quickly. So we are always eager to hear from you and to hear what's going on.
And to add, actually, it's not just for clinical trials. Like, even if you are on a standard immunotherapy, it's important for you to communicate those side effects with your oncologist. Sometimes, as I said before, these side effects can actually become really serious. So you have to bring it to your attention of your oncologist. It might be nothing, but it's important to kind of have them on board.
Yeah, and the other thing is that, we're all sort of learning, how to deal with the immunotherapy side effects because it's such a new agent. Chemotherapy, radiation, surgery, we've had experience with this. Here, what happens is that as we're treating more and more patients with immunotherapy, we're learning that it's a little bit more complex than sort of saying that this is disease-related, age-related, or immunotherapy-related. So there are multiple things that take into account. As was mentioned, how you're feeling clinically. If you're looking really better, but your clinical, your scan looks a lot worse, but your tumor markers are going down, what I usually do is I just sit tight. And I say, we're normally going to scan in 3 months or 2 months. What we'll do is we'll scan in 1 month or in 6 weeks. So we'll move the scan sooner. With immunotherapy, there could be a delayed response, which is what's called pseudoprogression, in which what happens is the immune cells, so imagine all of a sudden you're opening up these gates, right? And then all these cops are going in to contain a crowd. And you're just sort of at the helicopter where you can't say whether it's a crowd or is it the cops. All of a sudden you're seeing the crowd doubled in size. So what are you going to think? Oh my God, this is a terrible situation, right? But at the same time you hear there are no gunshots, there's no smokes and things like that, right? So what you're going to do is you're going to just sit tight, wait for a bit longer, and all of a sudden that crowd is going to dissipate. And that's what we see. So you have to have really an experienced person giving you immunotherapy so that they understand these nuances and they don't pull the plug early and move on to a different treatment. I'll give you a very quick example. There was a patient who I saw with a high-grade neuroendocrine tumor. And this patient was thought to have hepatocellular carcinoma, for which immunotherapy now, it's a GI cancer, so it's liver cancer, so associated with alcohol, Hep B, Hep C, and fatty liver disease. And, incredibly, 7 years ago, we had one drug, which didn't really work. And after that, now we have 5 approved drugs. And now they're combination drugs. So this was just mentioned in GYN, lenvatinib in combination with immunotherapy. Again, very effective in hepatocellular carcinoma. So what happened was that I was supposed to take this patient and put him on a clinical trial. The reason being is that targeted therapy, which means not targeted therapy as far as systemic therapy or targeting a mutation, but here what was happening is that interventional radiology, whenever there was a lesion that was coming up in the liver, we're going ahead and blocking those blood vessels with beads. So you're starving the tumor dies. And while he was getting this treatment, there were lung nodules that appeared. So the patient was sent to me and said, okay, this patient has failed this treatment and needs systemic treatment. So when I biopsied the lung lesion, it came back as high-grade neuroendocrine tumor. So that was a little bit puzzling. But remember, high-grade neuroendocrine tumor 2 years ago is treated as small cell lung cancer. Combination chemotherapy, fairly significant side effects, and really median overall survival, you're looking at less than a year. And then what happened was that I also biopsied the liver because I thought that maybe this patient has 2 different types of cancer and turned out also high-grade neuroendocrine tumor. Okay, so I was like, okay, I'm going to have to start him. I don't have a clinical trial with immunotherapy. I'm going to have to start him with chemotherapy. And my rule is that you have to have imaging, when you're starting treatment, 4 weeks. Anything more than 4 weeks is a little bit too far out. You're not going to have a good baseline. To give you an example, if the tumor is this big, and then as time goes by, it becomes this big, and you did not scan, and you started treatment over here, and you're using this as an example, and it becomes like this, you will think that the tumor grew, which is not the case. So I literally got a scan, and he's supposed to get the chemotherapy the same day, and when I look at the scan, I have a habit of looking at the scan myself. There are no lung lesions. We're talking about lung lesions, and the report says incredible treatment response. And I called the radiologist and I said, I think that there's a mistake. This is somebody else's CT chest. I have not treated this patient at all, right? And they're like, no, and this patient is doing really well. So instead of giving chemotherapy, it made me realize this patient is telling me something. And my hypothesis was that the patient's own immune system is actually attacking the tumor. So by me going ahead and biopsying these two different sites, disrupted this camouflage. And the immune system realized that it's being faked out and went and attacked the tumor. We waited for another 4 weeks and scanned, no lung lesions, and guess what? These liver lesions are breathing. Part of it is growing, part of it is shrinking by itself. So then I had done the mutation analysis, and turns out he had a very rare mutation called POLE mutation, which is an indicator that this patient would respond to immunotherapy. Now this patient works full-time and is on immunotherapy for the last 2 years, and sometimes wonders whether he even has cancer and whether we are even being honest with him or not, right? So the point is that, chance always favors a prepared mind. So ask. If something is different, don't just brush it off. Push your providers.
It's an outstanding example. We have 5 minutes, so we can perhaps take 2 questions.
I understand that if you do immunotherapy and then go back to targeted therapy, it increases the side effects of the targeted therapy?
That's an excellent question. I think, in lung cancer, as I said before, we have a lot of targeted therapy options. And it's in the setting of lung cancer that we first started to notice that when you use targeted therapy, certain targeted therapies, especially EGFR inhibitors, along with immunotherapy, that can actually increase your risk for some of these side effects, especially pneumonitis. And also we've seen that in melanoma, where like patients who were previously treated with immunotherapy and had progressed and have BRAF mutations, they subsequently went on to get like BRAF inhibitors, and that puts them at a higher risk for having liver toxicities. So you have to remember, the immunotherapy drugs, even though they have a certain half-life of about 1 month, the receptor occupancy or their action can last months after you have the last dose. So we are beginning to realize that when you have targeted therapy after immunotherapy or along with immunotherapy, then that can certainly put you at a higher risk for having certain side effects. So that should be something you need to kind of watch very carefully.
This is a question for Dr. Friedman. Can you speak to the challenges and opportunities in treating sarcomas with immunotherapy and also the risks with phase 1 trials? There's just very little data.
Yeah. So I can speak to a small proportion because I do take care of patients with uterine sarcoma. So I don't want to speak too broadly about sarcoma because it's a collection of a hugely diverse diseases. But so yes, immunotherapy in uterine sarcoma has thus far been disappointing. There are a couple trials that have been published where the response rate to single agent nivolumab, which is a PD-1 blocking antibody, was 0%. There was a larger basket study of sarcomas that was published by Sandra D'Angelo, who's one of my colleagues at the Sarcoma Service at Memorial Sloan Kettering, where the response rate to combination therapy, which is ipilimumab or Yervoy plus nivolumab, was also fairly modest, along the mid-teens, with most of the responses seen in a subset of sarcomas like pleomorphic. So uterine leiomyosarcomas and other sarcomas continue to be a very challenging set of diseases to treat. Chemotherapy remains the mainstay of treatment. I wish I had more uplifting things to say. I think that there are some interesting clinical trials looking at adding immunotherapy to a backbone of chemo. So for example, there's a study that's being done in LA at the Sarcoma Center that's associated with UCLA, looking at adding immunotherapy to a backbone of trabectedin, which is an active chemotherapy for sarcoma. So I think that there are some interesting opportunities out there, but I think kind of the option of treating uterine sarcomas with single-agent PD-1 is really not that exciting. In general, phase 1 therapies, I encourage my patients to look for them. The point of a phase 1 trial really is to establish safety. We're not even really necessarily looking for efficacy. So patients kind of have to understand that going in, and that a lot of them are also kind of first-in-human drugs, but they do offer an opportunity potentially to gain access to drugs that we think are promising or should hopefully have some efficacy.
Unfortunately, that is all the time that we have for this round of Q&A with our experts. You will have an opportunity during lunch as well as during the afternoon breakout sessions to interact with them. So for now, I'd like to thank Dr. Adams, Friedman, Manji, and